these cases is. So I remember that time always, violence against doctors cannot be tolerated. This is always there. Every time there's a violence which occurs, MARD goes on strike, all residents goes on strike. You analyze 90% of time, it is a communication gap between the patient and doctor. And that is a common problem. So how do you really build that? So that's the reason we developed this attitude, AETCOM. So AETCOM has many components. I'm sure it is available. All of you who have come to AETCOM should know about AETCOM. Now, when we developed first, it was the first module of professionalism. Actually, if you really see, the US started medical professionalism module in 2004, American College of Physicians, and they have their module of ACP. Many other countries tried to start. We took about 10 years later, but we had to Indianize it. Every case has to have contextual. Rather than trying to copy-paste, if it had done copy-paste, I'm sure it would have been much faster. But knowing that we have now 718 medical colleges, we need to do that kind of care. So we had a vertical implementation across curriculum. So we had now many teaching methods which were used. I'm sure seminars, guest lectures, and small group discussion. But of course, many new things have come up, like movies, reflections, self-directed exercises, debates, theater of oppressed, and many more. So now AETCOM has been, people have been trying to use different methods to teach this. So attitude communication program was introduced by Medical Council of India in 2018 as a holistic development. And despite its importance, program started with several challenges. So what were the challenges people faced? Now let's start with challenges of AETCOM. First thing is at a teacher level. Number of teachers required. See, AETCOM has to be taught with a small group discussions. Now we have 713 medical colleges. By today, 2 may have increased also. I really don't know. Average 150 teachers per college. 1.05 lakh teachers. We have 5 lakh students, undergraduate students. See, Indian medical system now has become too huge to handle. Our ratio is 1:5. Now we need adjunct teachers for small group teaching. It's very difficult to really run a program with so many things and all competencies and all. We need adjunct teachers. So many colleges have now taken adjunct teachers. Now this is a basic problem, the number of teachers required. We are overloaded with practice, we are overloaded with these clinical work, teaching, documentation. So overload is one of the big issues. Lack of trained faculty. How many faculty understand how to teach attitude, ethics, and communication? It's very easy to say, we feel if I pass MD, I'm a good communicator. It is not so. Even simple public speaking, the way you speak, the way you talk to patient itself needs a lot of involvement. I'm sure palliative treatment itself, when you talk to a patient who needs a palliative treatment, it's a totally different concept than what normally we talk with the patients. Who teaches you? If you don't know about teachers, how the students will learn? Limited experience in teaching ethics and communication skills, and need for specialized training. And if you really see this Dr. D'Souza's paper, very interesting paper, do we need teaching ethics and communication? This came in last year. So we said, okay, we convinced National Medical Commission and MCI to start this whole faculty development program. The whole 32 regional centers and 15 nodal centers, and we treated almost 90,000 trained teachers for small duration courses. But remember, it has its own limitations. Though it's a huge effort, it's a first-time effort in the world, but it has its own limitations to do this. And if you really see our report, you can read about it on the NMC site. The second is motivation of teachers. Many teachers think, oh, this is a useless program. Teachers are going to really learn about this. See, unfortunately, all these principles like humanities, there is a complete divide into the literature. There are some who follow it, some who don't follow it at all. And this is what it is. Busy schedule. My clinicians have a busy schedule. And attitude towards humanities. Dr. Anand Krishnan wrote a wonderful article on this, changing roles of medical education. And then he said, okay, now we want our teachers to do more small group teaching, attitude and ethics training and skills rather than only knowledge. So are our teachers really interested? Do they understand what they are really doing? Are they skilled to really do all this? Second is a curriculum. You know, we already feel we are a very busy curriculum. We have hour to hour marked. But please remember, all of you, I must tell you, please allow students also to learn on their own. The first thing what we do in CBME, we have introduced this whole self-development SDL. The whole idea was during LDL that the teacher teaches students what are most essential. Let students learn. Today's students are much smarter. They have much more resources. If you really see, most of our students will have an iPad with all medical books on that iPad. We don't need to give the same knowledge through slides. We need to give them a knowledge which is something like a decoction, a small, which is really important, and for which you don't require a lot of time. So you have spare time, you use it for these purposes. Place and teachers is a logistic issue, which many times people would do. So logistic of managing large number of students in a stipulated time frame, I think this is some of the major challenge we are facing. You know, many colleges have now 250 students. And you find 250 students, how I'm going to do small group teaching? How am I going to do uniformity into them? These are the challenges. Individualization is missing. I think this is where the technology can really offer great help to you. And this is where you can record sessions, put it on WhatsApp, let people go through. Good to have definitely, you have platforms where students used to use. Then curriculum integration. I think somebody presented a very nice paper on integrating AETCOM into already packed medical curriculum. The curriculum restructuring to create dedicated time slots for attitude modules. You know, try to see that you can mix your modules of your subject and AETCOM module also. This could be another way of looking at an AETCOM. Embed AETCOM modules with clinical rotations and use of case-based learning to connect ethics with practical sessions. That's the way you could really save on time. There are n number of books which have come on AETCOM. So many guides, manuals. I think Olinda's book is probably I think I was really like that book, the way she has really gone through. Now you will find people have come out with so many kinds of material on this. I can show you, if you go, many commercial and non-commercial booklets and courses have come on AETCOM. That means people have realized the value. They have made an attempt to do this. If you go on the literature, in India you will find, I mean hundreds of books have come. Students' initiative for AETCOM have also come. You know, some students have prepared manual for second BBS. I was very happy that students came out on their own and they prepared a manual for second BBS, first BBS, third BBS. That means students also are thinking that this is something we should do. What are challenges for students? Students, 92% opine. You only saw publications which have come on AETCOM. 92% students opine that AETCOM module will definitely improve their communication skills with the patients. They also feel that such training should be integrated in regular teaching curriculum and done continuously in semesters. So if you really see, most of the students are not problem. Teachers find it difficult. Students have accepted it very easily. Overcoming some students' perception of AETCOM as less important as it is not part of the NEET. That's our problem. Everything is related to the NEET. If it is not in the NEET, it is not good. Whatever converts into marks into the NEET is a good curriculum. Now that's the perception we want to come out. You know, ensuring active participation. Ensuring students take AETCOM sessions seriously and recognize importance. I think this is where the role plays and real life case discussions make learning more engaging and relevant. How do you engage the students back? This is where real life scenario, real cases, practical kind of demonstrations make a lot of difference. Henry Colt is one from Los Angeles who came out with this wonderful book, The Picture of Health. You know, I don't know you ever read, but please read this book. It's a very wonderful book. And he gives scene by scene, and he also tells you what should we really teach AETCOM through this. Very interesting. Patch Adams And many of these books, I mean, I'm sure I can give n number of, there are sessions on this, people have written papers on this. There's a Bollywood masala on, and the AETCOM. I'm sure there is Tollywood, Mollywood, every will have the attitude and ethics components which will be there. And you will see, so many social responsibilities and movies. And I'm sure every day when we see on a Netflix or in a movie, we can definitely find attitude and ethics component into this and communication component. And this is what we should really use. That will engage students back to us. Another issue what I face is the cultural barriers, addressing diverse cultural backgrounds in communication training. We get students from all backgrounds. We want to bring them into something which is acceptable and overcoming the hierarchical mindset of doctor-patient relationship. And this is where I think a case-based analysis where culture-bound symptoms are not uncommon with primary care in India. So in other issues as well, as we argue that such cases need to be properly understood and they should be involved. Resistance from both faculty and students to the traditional teaching methods, who are accustomed to the traditional teaching methods. They are usually say that, okay, the lecture has to be. There are still so many teachers today have same set of slides, which even students know for that particular lecture, they come and deliver. कि आज lecture है, मैंने 10 साल पहले slides I had made, I'm going to present the same slides. I think we have to come out of all that. We need to bring out all this. So we need to have awareness campaigns and we need to have challenges and implementation beyond this. Peer learning is something which we should really use. This was a very interesting paper I read. Teaching AETCOM modules in physiology through peer-assisted learning. One of the more powerful way of teaching students ethics and attitude is through their peers. I was also always influenced by my peers while my development. Don't underestimate the power of peers. So developing reliable, and another thing is assessment methods. It is said that AETCOM is not being assessed, it is not into the final examination. So what is the importance of this? Many of the students are very practical. So we need to really tell them, and this is the teachers who need to variety of assessment methods like OSCE, reflective writing, peer evaluation. Now these will widen the horizon of a student and make him a better physician. Now we have to really convince our students on this. Developing appropriate evaluation techniques and standardized assessment across institutions. There have been approaches, there have been people who have worked on this. I'm sure there are, if you really see, Adukoli sir had his own one paper, and so many papers are there. There's a very nice book, I don't know how many of you, that is used by the WPBA, Measuring Medical Professionalism by David Stern. I think these are the people who have said faculty observation of students' professional behavior, using critical incident reports, using reflection and use of portfolios. I think Pondicherry is one place where somewhere places portfolios are used. Now these are the places where you find the assessment of this is much better. And if you see if you go through the literature, AETCOM has churned so many papers of all aspects. If you start reading, I'm sure there are now hundreds of papers on AETCOM. It only tells you that people are interested, people want to do something, though there are gaps and difficulties, over a period of time, pathways and solutions will come. It's a continuous process of developing, I think it's churning the mind of people so that we get better and better collaborative and complete output. Now, I personally feel administration is also an issue for challenges. All birds find shelter during a rain, but the eagle avoids rain by flying above the clouds. Problems are common, but attitude makes the difference. That was Abdul Kalam sir. I think having a conference on the grace itself is an eagle's attitude. You must remember that. So you have gone one step above, and that's what we should really do. So the priority, motivation, and resource crunch. So I feel many times some institutions, I'm sure your institution has a lot of background, and therefore an attitude has a lot of place in this. Many institutions you see they have, but sometimes a commercial institution may not have this. So we need to see how do we bring that attitude into this. So limited time allocation in a packed schedules, lack of dedicated spaces, limited resources such as standardized patients, simulation lab, teaching materials, Collaborative skill labs. So what are solutions and ways of teaching AETCOM? There are some solutions which I would like to give. One is make sessions interactive. Don't make a theory-based lectures. No lecture of yours should be now a theory-based lecture. It has to be an interactive lecture.